department. It's now time for our final session. Dr. Swan was supposed to be here, but he sent his apologies. He had to go away on urgent business, but his abstract is available in the West Indian Medical Journal. We are on our final session for today. It's last, but it's not the least, because we have several noteworthy speakers, both locally and internationally. Our moderator for this afternoon is Dr. Gabrielle Hunt Burrows. She's the former CME director and now the current Deputy Medical Chief of Staff. It is our pleasure to have her host this session. So without further ado, Dr. Burrows.
Thank you, Dr. Halliday. I hope that everyone is certainly enjoying and learning from all of the very relevant and interesting presentations that we have been having so far for our research day. And so once again, I want to thank all of the presenters who have taken their time to come and contribute to this research day. And we will now begin the 8th segment. And our 8th segment relates to obesity prevention and treatments. Our first keynote speaker, Dr. Emanuele Lomenzo, is a native of Italy. He received his medical degree from the University of Catania in Italy, as well as his PhD. Dr. Lomenzo has completed a general surgical residency at Thomas Jefferson University in Philadelphia, Pennsylvania, and also a clinical fellowship in advanced laparoscopy, endoscopy, and bariatric surgery at Cleveland Clinic in Florida. He is an associate professor of surgery and the director of the Department of Research at the Cleveland Clinic in Florida. As you might have already gathered, his main clinical interests and research interests relate to laparoscopic and endoscopic hernias, abdominal wall reconstruction, as well as laparoscopic surgery related to morbid obesity. He's an author of more than 85 peer-reviewed manuscripts, 25 book chapters, and some 200 abstracts, well qualified to speak on this subject. And so let us welcome Dr. Lomenzo.
Well, thank you very much for the nice introduction and for the honor of the invitation. This is a great event. Obesity, of course, is a major issue worldwide. I don't think I realized actually until yesterday the stunning percentages of the incidence of obesity in the islands. So this is certainly something that is very pertinent to today's discussion. I have nothing to disclose. These are the CME instructions. The slide will be at the end of the talk as well. So we're going to outline a little bit of the epidemiology of obesity. We're going to discuss some of the major comorbidities associated with obesity. We're going to see what the surgical options are and the results of the surgical options, and then a few slides about our own experience at Cleveland Clinic, Florida. As we all know, obesity is a worldwide epidemic. Some people use the term globesity these days. 1.7 billion people are considered overweight, and 400 million of those are actually obese. In the US alone, 33% of the population is obese, which is, again, nothing compared to the 78.2, if I'm not mistaken, in Bahamas. And 10 million are class 3 obese patients. It's interesting to see, at least in the US, how the numbers of overweight individuals are somewhat stabilized. However, the numbers of extreme obese have significantly increased. There we go. Only the green button. Yes, I know you had that problem before. So And this is just, again, to put in perspective, if we look at the statistics from the 60s to today, we see how the number of overweight patients, percentage-wise, has not changed significantly. But when it comes to the obese, and especially the extremely obese, there's significant increase in those numbers. We just heard in the previous session how childhood obesity is very prevalent. This is just a visual feedback of the same concept. The darker the red shades, the higher the likelihood and the higher the prevalence of obesity. The causes are multifactorial, genetical, behavioral, environmental. There's no question that industry is putting a lot of pressure on all of us. They make larger portions. When we compare common foods in the last 50 years, there's 3 times as many calories as they used to be in their portions. They're pushing us to eat more often, maybe even a 4th meal in the middle of the night. So of course that doesn't work in our favor. Technology also is not helping us either. And if you notice by the style of the model of the car, this is a picture that is a few years old. But today things are not different. Maybe we walk the dog with an iPad now or with an iPhone, but the concept is the same. We're not burning as many calories. But obviously the main component is the one that we know the least, is the genetical aspect of things. Probably the adaptation over the generations of lack of food, that keeps going today when food is available 24/7 in larger portions. We know that obesity affects everything from head to toe. These are just some of the diseases that are linked to obesity, none of which, or most of which, are not transmissible, except for those genetic factors that, again, we don't know much about. And the reality is that at the end of the day, all those comorbidities affect survival. And it's very well known how being obese takes a toll in the years of life. And that's just some statistics that I'm sure everybody's aware of. So what can we do about it? I'm certainly not qualified to speak about in detail of any of those options, but we do know from studies that none of those options, usually in the big scheme of things, have a successful and long-lasting success. Whereas surgery seems to be one of the tools, and I underline the word tools, that has more effectiveness over time. But it's just a tool, because a tool by itself, without those other intervention, is not sufficient either. That's why I think we have to move away from that dichotomy between medical or surgical treatment of obesity. There's no such a thing. There's just treatment of obesity. And it's a combination of all the interventions that hopefully will give us the best answer at the end of the day. However, bariatric surgery is definitely becoming more prevalent. These are the latest number released from 2015 from the American Society for Bariatric and Metabolic Surgery. In the US, we have 196,000 interventions. The breakdown is less important. It's more important the fact that the numbers keeps going up. And the reason is because they are effective. This is probably the best study that we have in bariatric surgery in terms of follow-up, in terms of completeness, in terms of homogeneity of the population that is involved. And it comes, of course, from Sweden, in a society where medicine is socialized and where access to data is a lot easier than in other parts of the world. And the 20-year results of that study shows that the weight change is significantly better after bariatric surgery and is consistent, and it's kept over time. Although there's no question that there's some degree of weight regain. Nobody is hiding that point. But still there is a significant difference compared to the controls. And that, of course, translates into the decreased mortality, which at the end of the day is what we really care about. And that's the delta between controls and surgical patients is quite obvious, and is obviously statistically significant. And another way of looking at the data from a different perspective, from a different study, is looking at the all deaths from any kind of disease in a controlled population, which is 26.5 versus 50% in the control group. 26.5 is the surgical group. So when bariatric surgery started in the 70s, people didn't know much about it. They were doing procedures that, for other reasons, people were losing weight, but it was up until the 90s, the mid-90s, were one of the really first pioneers of the term metabolic surgery, Dr. Porras, really made the association, because weight change is important, but it's not the only advantage. He obviously found that diabetes in the particular study had an incredible number of improvement or even resolution after these procedures, but we had no idea why, and we all thought that was related to weight loss and nothing else. Of course, there's a lot more to it. And diabetes is one of those non-communicable diseases that, of course, is the one that it's probably has the most prevalence. 1 in 10 adults have diabetes. The numbers talk about 552 million by the year of 2030. And there's a clear relationship, actually an inverse relationship, between BMI and age of onset of diabetes. In other words, the higher the BMI, the earlier the onset of diabetes is in somebody's life. And if to that we add high blood pressure to the mix, the age gap moves even to a younger amount. So definitely pretty tight relationships. After Porras, multiple authors continue to prove the benefits of bariatric surgery. This is another study by Dr. Buchwald, comparing different type of operations. Again, the purpose of this talk is not to go into details of the different kinds, but just to tell you that the difference is really on the type of procedure, the restriction versus the malabsorption versus the combined, which are also terms that today are probably going to be abandoned, because we're talking about more of the mechanism of action of these procedures, more so of the anatomic changes that we produce by surgical interventions. We'll go back to the Swedish obesity study. We're going to do that several times during this talk. The changes in diabetes, hypertension, and other comorbidities is pretty stunning. But again, this seems to be the theme after these procedures. So, but why surgery for a metabolic disease? In the study of over 122,000 patients that were followed for 7 years, it was noticed that the potential for remission, either partial or complete, and a prolonged remission was extremely low. We're talking about a 0.07% chance of a prolonged complete remission of diabetes. Of course, that means that although possible, it's extremely difficult that patients will have their diabetes resolved or reversed by interventions that are just medical. Well, I shouldn't say just, because there's a lot of interventions, but medical, dietary, psychological, and so forth. That is the reason why multiple authors starting to look into the specific issue of diabetes and bariatric surgery. This is probably the best known of those studies, the Stampede trial that started the Cleveland Clinic in Ohio with 150 patients. The inclusion criteria were purely based on the hemoglobin A1C levels. And included patients with a variable BMI. And by the way, the BMI that included these patients are also patients that did not qualify by FDA criteria to have bariatric surgery, because we're talking about BMIs lower than 35. They were randomized between 3 interventions. One arm was intensive medical therapy. The other was medical therapy in addition to gastric bypass, and medical therapy in addition with a sleeve gastrectomy. The surgical group, as expected, lost more weight, but more importantly, the glycemic control was significantly better in the surgical group, with the bypass having an advantage to the sleeve gastrectomy, although that was not one of the purpose of the study, and certainly the study is not powered enough to demonstrate that difference. This is, again, the SOS study, where we basically see similar results. But also, in the same study, in the latest article, they talk about prevention of diabetes. And this is one of the few studies that actually tries to prove the point that if we follow those patients in the two arms that did not have surgery, that did not have diabetes, and compare the group with surgery and without surgery, we see a significant difference in the number of patients that actually develop diabetes de novo. So this is also an intervention that could prevent some of these diseases. This is just a summary of the most recent randomized trials between medical therapy and surgical intervention as it pertains to diabetes. And without going into many details, the message is the same. Certainly the surgical arm has an advantage. Dr. Schauer, which is the lead authors of the STAMPEDE trials, just a few months ago in February of this year, published the 5-year data of the STAMPEDE trial. Again, just to show how those results really are long-lasting, and it's not just a 1 year or two type of intervention for these procedures. And that is also reflected in the number of medications, in the which is not always a complete resolution. It could be just an improvement. But that's the reason why the medical and the surgical aspect of things should work hand in hand to have best results. So what about doing these procedures in a lower BMI? That's been very controversial. Again, the FDA criteria, the FDA approval for these procedures does not include patients with a BMI less than 35. However, there are several studies, probably 32 or so, with 3 randomized controlled trials that look into that option, especially from the Far East, where the incidence of diabetes is very high, although the incidence of obesity based on the definition of BMI that we use in the Western world is quite low. Nevertheless, the advantages of those procedures are quite obvious, but there's not a lot of solid data today that is pushing the FDA to really change the indications, at least for us yet. But at the end of the day, we have to remember that the genetic component is very important, and a lot of the issues that have to do with diabetes are genetically related. For instance, the factor VII like 2, which is a strong contributor to diabetes type 2. And maybe because of decreased beta cell mass, because of impaired insulin processing or release, or glucagon-like peptide signaling, or even insulin resistance. And few studies try to associate or try to predict the results of bariatric surgery on a more molecular and genetical aspect by looking at different class of patients. And it's obvious from this study, although relatively small, 99 patients, that the genetic component potentially is a predictor of success after this procedure. That's why classifying this procedure as a restrictive operation or a malabsorptive operation is not enough, because there are certain patients that genetically will not respond as well as others. And that's where I think the future is. Switching gears to another problem, cardiovascular effects. Again, the SOS study, the long-term results of fatal cardiovascular events versus the total cardiovascular events. Again, you see the delta difference between the blue, which is the control group, versus the orange, which is the actual surgical group. We conducted our own study by measuring the Framingham score in our patient population of over 1,000 patients, and this study was published in 2017. 358 patients were included in the study because met the criteria. The majority of them underwent sleeve gastrectomy. Of course, the majority of patients were women. And 12 months postoperatively, the absolute risk, the absolute and relative risks were significantly decreased in both men and women. And more importantly, at least the calculated heart age was improved in 7% of the men and 7.1% of the women. And speaking about heart, this is another study that we're going to be presenting at ACS next month, where we actually looked at the changes in the heart geometry by echocardiogram in patients that had bariatric surgery. In other words, the differences of bariatric surgery in terms of blood pressure regulation, cardiovascular risks, and so forth can be measured by structural changes in the heart. And again, without going into details into every single parameter, but there is quite a significant change in the shape of the heart. And that translates into not only function, but chances of arrhythmias, atrial fibrillation, and so forth. So that's an important aspect as well. Let's change completely organ. What about the liver? Non-alcoholic fat liver disease today is the most common cause of liver disease worldwide, more so than hepatitis C, and increases the risk of mortality by 1.34. Bariatric surgery seems to be, again, one of the most effective treatments for non-alcoholic fatty liver disease. Certainly the association between the liver disease and obesity is well known, but again, the genetic component is very well represented. We all know the different stages of non-alcoholic fatty liver disease, from the type 1 with just simple steatosis, still a reversible stage, to worsening stages where inflammatory processes start setting in, and then you have actually injury of the hepatocytes with ballooning, eventually leading to fibrosis and cirrhosis, which is the irreversible state. The medical treatment, although available, although with some good results, has given issues in terms of longevity and in terms of potential complications of other organs because of the toxicity of some of these medications. Whereas bariatric surgery seems to be able to reverse some of these problems, obviously at the very early stages, or decrease the chance of progression into the worsening stages. In this case of 109 patients with NASH, there was an 85% resolution of NASH, and the patients that did not exhibited as much as resolution were also the patients that did not have good results because of less weight loss than the other cohorts. Let's switch again to another organ, and that's the renal function. Renal function and kidney issues are very closely linked to obesity. This is another paper of ours that will be presented at Obesity Week in a couple of months with 299 patients, where we calculated the chronic kidney disease epidemiology collaboration GFR index, as well as the Framingham risk score. And we analyze and we stratify patients between chronic kidney disease stage 2 and above, with patients that had a normal function. And it's not unexpected that the cardiovascular risk was higher in the patients that were also had an impairment of the kidney function. But more importantly, that risk decreased after bariatric surgery. And in fact, at 12 months, the kidney function improved statistically. The absolute risk factor, both from a cardiovascular and a kidney standpoint, decreased statistically significantly compared to the patients that were in a class of kidney risk that was less than 2. And finally, I just want to very briefly mention cancer. We heard today the association between prostate cancer, GYN-related cancers, and obesity, obviously. And again, just to give you a visual feedback of the long-term SOS study results, again, the delta between control and surgical interventions. This is the procedure that is the most common today. It's called the sleeve gastrectomy, or gastric sleeve. It's a procedure in which we modify the anatomy by removing approximately 80% of the stomach along the greater curvature, with the idea to preserve the normal passage of nutrients and absorption of nutrients, because we're not altering the way the food progresses through the intestinal tract. However, we remove what we think are some of the mediators of specific diseases, or at least regulators of appetite, ghrelin in particular, maintaining a natural restriction, which is the pylorus, and also, of course, providing restriction in terms of calorie that can be ingested at any given time. But we do know that the gut has a mind on its own, and it's not simply a conduit. It's an organ, both an endocrine and exocrine organ. So we do know that there's multiple factors that play a role in the development of these diseases. And some of those factors have significant changes after bariatric surgery. GLP-1, GIP, PYY, ghrelin are just few of the enteral hormones that have a significant change and rebalancing after this kind of operations. But it's a lot more complex than that. There's bile acid metabolism that is involved, especially with the new findings of the nuclear receptors changes after changes in the secretions and absorption of the bile acid metabolist, changes in pro-inflammatory markers at the level of the visceral fat, obviously, and more importantly, the alteration of the gut microflora that is becoming more and more studied over the last few years. So all these options can eventually manifest themselves with resolution of diabetes and other comorbidities. Of course, the changes that occur at the molecular level that eventually will end up in the end organ changes. And we all know the foregut hypothesis and hindgut hypothesis of diabetes and diabetes resolution. The foregut basically says if we exclude the duodenum from the from food to reaching the duodenum and activating some mediators that are not well known, as opposed to other believe that the hindgut hypothesis, where the issue of changes in the intestinal content is because of rapid delivery of chyme to the more distal part of the intestine, where specific mediators, maybe GLP-1, can be overly stimulated, and in terms stimulate insulin secretion and beta cell proliferation. And of course, this is all under the premises that diabetes is a balance between incretin and anti-incretins. And of course, when there's an anti-incretin overproduction, you develop diabetes. If you can stop that overproduction, then you can reverse the disease process. So the Cleveland Clinic, switching to the last part of my talk, is our experience for the last more than 15 years now, 17 years, more than 6,000 patients. This is the breakdown of our procedures. There's also several thousands reoperative interventions, so revisional surgery. In our study that we published last year, reviewing 1,020 patients that underwent sleeve gastrectomy, we found that there was a significant incidence of comorbidities, hypertension in 80% of the patients, diabetes in almost 90% of the patients, sleep apnea, and overall the improvement was again very significant. 91% had improvement of hypertension, diabetes, type 2, 57%, 99% sleep apnea, and also hyperlipidemia. This is the breakdown of what the actual weight loss was for this patient, and we have a now 8-year follow-up. We should probably do another follow-up of these patients at the last 3 years of our experience, but the excess weight loss was still well into the 70 percentile. Overall, early readmission was 3%. We had one leak over the now 1,600 patients for primary sleeves, strictures. Gastroesophageal reflux disease is one of the controversial issues after this procedure that we're still trying to understand, although incidence was 6%, but this could be a debilitating issue and also could be a reason for conversion to other procedures such as gastric bypass. So in conclusion, metabolic surgery is effective in reversing multiple comorbidities, and the mechanisms are not well understood. Certainly there's anatomical reasons, hormonal, biochemical, microbiological factors that are all involved. And of all the procedures, sleeve gastrectomy seems to be a good compromise between the amount of success and safety. And there's no question that maybe gastric bypass has some higher likelihood of success in specific diseases such as diabetes, but certainly you pay a slightly higher price over time. I thank you again for the opportunity to address this audience today and for the invitation, and I'm happy to entertain any questions.
Thank you, Dr. Lomenzo. And at this time, we will open the floor to any questions.
Dr. Emmanuel, your talk was interesting and very informative. I have 2 questions for you. Firstly, how much is the cost of this procedure in teens and adults? And secondly, my 1-year-old niece, you mentioned something about genetics playing a big role. My 1-year-old niece, if she now is sent to China and lives there for 20 years, would she be like the Chinese in terms of their culture, their size, their habits, their thoughts? Those are my 2 questions. Thank you.
Excellent point, excellent point. So as far as the cost of the procedure, insurance companies, not all of them, but they cover these procedures. The technical aspect of this procedure, the fees of preoperative workup, preoperative counseling, and so forth, the operation itself, the anesthesia, and the recovery, it's bundled. We do certainly offer specific packages for people that want to pay out of pocket. We don't encourage that because the insurance companies do cover for this, and because we find that people that pay out of pocket, they're also the ones that tend not to follow up afterwards. They pay out of pocket. They pay out of pocket. So I can give you certainly a ballpark idea, because thankfully I'm not involved in that decision-making or process, but depending on the type of procedure, we're talking about anywhere between $15,000 and $20,000. And that, of course, includes also postoperative appointments and care for the year after, because, like I said, these are tools. If we don't give you the instruction manual to the tool, we'd be doing a disservice. As far as the second question, genetic is a very important part. Unfortunately, my personal belief is that there are also stronger factors that are socioeconomic that sometimes override the genetic component. And we know that by early study of immigration in this country for people from the Far East, that then they move to this country and they assume the exact same risk factors, maybe after a generation or 2 of the native U.S.
Can I just add something to that? Because I was in China, coincidentally, earlier this week, at a big conference they had about obesity and childhood obesity. So if you moved to China right now, you would get obese because they're big.
Thank you. Sure.
Hi, good afternoon. Very interesting talk and relevant to our population. You had mentioned the risk of developing esophageal reflux after bariatric surgery. And I'm wondering if preoperative esophageal manometry is a part of your workup to identify patients who may be at risk of developing severe reflux after surgery.
Sure. This is specific to sleeve gastrectomy because gastric bypass is probably the best surgical intervention that we have for patients with reflux disease. So we do use manometry and pH, 24-hour pH studies, although it still remains unclear what the role of those studies is. There's controversial evidence that sleeve gastrectomy actually improves gastric emptying, which is one of the potential issues with reflux disease, but there's also no question that there's an increased interluminal pressure after a sleeve gastrectomy. So what we do is when somebody comes in and has a significant history of gastroesophageal reflux disease, we do perform endoscopies in everybody, 24-hour pH studies and manometries. If they have a very high Demister score, meaning that they have a very positive 24-hour pH test, we try to counsel them against sleeve and more towards bypass. But we don't have a lot of evidence about, nor us or nobody else, about the long-term effects. Thank you.
Thank you, Dr. Lomenzo. Dr. Neal is a graduate of the University of the West Indies in Jamaica. He completed a general surgery residency at St. Luke's Roosevelt Hospital in New York, subsequently completed his training in plastic surgery in Richmond, Virginia, at which time he was nationally recognized for his academic excellence. Dr. Neal is a board-certified plastic and reconstructive surgeon, in addition to which he specializes in surgery of the hand and maxillofacial reconstruction. And there's more to Dr. Neal than surgery. Dr. Neal is also a licensed mariner and pilot, but he is going to speak to us today about surgery. So today, Dr. Neal is going to speak about bariatric surgery, the Bahamas experience, microfractured fat as a megavolume filler for buttocks augmentation. Interesting. So let us welcome Dr. Neal.
Good afternoon, everyone. Can everyone hear me okay? No? Yes? Can everybody hear me okay? Yes. All right, great. Well, thank you very much for having me. I feel very privileged to be among such distinguished company. I enjoyed Dr. Heskey's talk especially because she's going to make me into a pescatarian, and hopefully Dr. Lomenzo wouldn't have to work on me if I get it all right. So microfractured fat for large volume gluteal augmentation. And I guess I advance it, right? Okay, so I'd like to thank the National Stem Cell Ethics Committee for their adherence to standards and their attention to detail and the good communication. Dr. Pierre and Dr. Anwala helped me finesse this manuscript, and the staff at my office puts up with me. Dr. Bruni helped me with slides, and Dr. Kaplan, when I called him to help, to ask if I could use his slides, actually said, just use anything you want, and he sent me more information than I could actually possibly use. So my appreciation. Disclosures, I really have nothing to disclose. Everything we did was in compliance with ethical guidelines widely established, no conflict of interest. All the patients had informed consent, and written consent was obtained before use of any patient-related images. Let me just start a little bit with the history of fat injection. We were very privileged to have Dr. Elouz live here with us in the Bahamas. He was originally from France, and he popularized liposuction. A very forward-thinking guy, got a chance to spend some time with him, and he proposed the idea in 1986 of using the fat that we were suctioning out as a graft for filler for various reconstructive uses. Shortly after that, Dr. Burkhalter presented a large series where he was injecting fat into the breast for breast augmentation. Big problem he had was that a lot of it was becoming necrotic and getting calcified in the breast, interfering with mammograms. the radiologists were up in arms. How were they supposed to distinguish between stipple calcification from cancer and steatocnecrosis or fat necrosis? Based on this, the American Society banned fat injection into the breast, and it was supposed to be a 20-year ban. We were commonly doing fat injection into the face from 1996, and it was something that we did a lot of because we recognized that for the face, a large part of the aging process was deflation, and this is similar to the buttocks. Sidney Coleman structured his book to finesse out a lot of the techniques that we were all in plastic surgery learning about. And Zook discovered that stem cells were located in fat, and actually we now know that fat has quite a lot of stem cells, on the order of 1 in 100, more than bone marrow. At the same time, Ivo Pitangui was popularizing a procedure called Brazilian butt lift, which I think we all have heard about. When the American Society banned fat injection to the breast, I pulled back from the procedure because obviously if you can get fat injection in the breast, the idea of injecting fat in a larger volume into the buttocks meant you had a good chance of getting calcifications, steatocnecrosis, resorption, this kind of complications. So when I talk to you about my relationship with fat injection, it's actually one of those love-hate relationships. It's not something that I do on everybody. And actually, I tell people, if you can't take a joke, I'm not going to discuss fat injection with you. Anyway, so here I was figuring out that if I couldn't inject fat, maybe I should look at butt augmentation with implants. So I went to the course, I did the 2-day course, and at the end of the course, I was very impressed with everything that was going on. I spoke with the 3 presenters who were internationally known, and between the 3 of them, their average complication rate was 30%. At that time, I wiped it off of my radar because there's no way I can get away in Nassau, Bahamas with a procedure that gives me a 30% complication rate. So here's why fat dies. You inject a fat globule, you get about 1 millimeter of oxygen diffusing in from the sides. If you have a 2 millimeter globule, you should be good. If you have a 3 millimeter globule, you're going to get some necrosis in the center. Very simple. Roger Corey tried to formalize and put this into a graphic, and in the middle you see the ideal relationship between the injection and the surrounding tissue. On the right, too much has been injected, you're going to get some necrosis. This slide just puts into graphic form the idea that you could do 100, 200, 250 cc's into an area and be okay. You try and push an extra 10. Now you push the limits and your tension is too high in the tissue. Now you decrease perfusion, you're going to lose all 260 cc's. So it's one of those procedures where, it's very attractive. You want to go do it, the patients ask for it, the patients want BBL, it's on TV. Why aren't you doing it, Dr. Neal? And there's still a lot of reservations that I have. So that's my approach avoidance conflict with fat injection. This graphic just says a little bit about compliance. And I think we understand that for the buttocks, you get a little bit more compliance, a little bit more leeway, but you still have to be careful not to push it to the edge. So the popularity of Brazilian butt lift, Dr. 90210 Extreme Makeover, a lot of the reality plastic surgery shows were doing it. But what you have to know is that the average Brazilian is maybe 5 foot, 4 foot 10, 95, 100 pounds. You take 300 cc's of fat and you inject 150 cc's on each side, you're going to make a difference. You take our Bahamian beauty here, and she's 5'10", she weighs 175 pounds, drop dead gorgeous, but you put 150 cc's into each side, you're not going to make any difference. So in the meantime, fat injection was on the rise. 2008, the American Society reversed the moratorium. The radiologist said, hey, you know what, with full field mammography, digital mammography, we can cone down, we can check the spot size, we can tell what is necrosis and what is cancer. Great. American Society declared 2015 the year of the rare because so many procedures were being done. The same thing was happening in Europe. And this had something to do with it. You know, we like to emulate our celebrities, and these two are known for their derriere. So I was getting real hot on the idea, and then this patient walked into my office. She had a procedure done in another country. She was getting fat for breast reconstruction after mastectomy. I think that black thing on the right was the nipple. But this is a very scary case, and now I'm pulling back again because this is very scary. So this is me in the jeans, and I want to go pet the puppy, but I keep pulling back because the puppy can bite. So now I want to find out more about the procedure. I go to Baker Garden Stuzen, a big cosmetic surgery conference in Miami. I take the course. I talk to the guru of plastic surgery over there who's doing a lot of butt injections. And afterwards, we're milling around. We're talking about the procedure. Hey, Greg, do you do the procedure? No. Why not? Because I'm scared of complications. I live in a small community. I really can't handle complications. It's very easy. What you do is just inject the fat into the muscle. Hold on a minute, did you say inject the fat into the gluteus muscle? Yeah, better blood supply, better survival. Well, shortly after that, there was a colleague of mine that had it done, and some of us might be familiar. She returned home with pulmonary embolism and died. So now I'm pulling back again. We started doing some stem cell work, and this is Kaplan's graphic. He discovered that the pericytes actually become stem cells, and the stem cells now, we call them medicinal stem cells because they're immunomodulatory. They control the T and the B cells, and they're also angiogenic, apoptotic, help with a trophic effect, so they can help a lot to build and maybe help with my fat survival. So we try it out, and at first I tried this on people who have degenerated disease of the knee or large joints. And we start refining fat, very simple procedure. I can show you the video while we're working. So you harvest the fat, you put it into a closed chamber. There's some steel balls that you do gentle agitation with. And after you break up the fat and lyse a lot of the adipocytes, which are the ones that are difficult to get to survive anyway, then you're left with what we call stromal vascular fraction and a good three-dimensional structure, which you can use as a filler, but which also has the additional benefits of lots of pericytes and a concentrated number of medicinal stem cells. It's good for for small volume only. These are some other applications of lipogems. Then this lady turns up in my office. She fell down the stairs. She has a huge bruise on her buttocks. The picture on the right is about 3 weeks after. The bruise still hasn't resolved. She's otherwise healthy. And this is how she ended up, with a large area of fibrosis and scarring in the buttocks, and the area above the depression is rock hard. So we figure we're going to do an aggressive liposuction with my most aggressive cannula to try and get rid of this fat necrosis. We're going to try after that to fill the defect. And one of the problems she's having is when she gets physically active and stretches the gluteal area, it hurts. So we have to try and find a way to help her. I'm not about to just jump in and do this procedure because you know my reservations. So I started experimenting on people who I'm doing liposuction or breast reconstruction, any other reason I had to do liposuction. Larger syringes, these syringes are huge, 240 cc's, different amount of stainless steel balls. We select the stainless steel balls based on not the size of the ball, but the space between them, because that's the fat that we want to break up. And we come up with the fact that 20 balls used for 2-minute intervals agitation gives me a nice particle size, less than 2 millimeters. And here's some histology. On the left, you see like a slit-like capillary, some adipocytes around it, and a good stromal vascular fraction. On the top right, you see regular fat tissue, and you can see all the adipocytes are intact. At the bottom of the slide, you see a lot of blood, and the heme, when it breaks down, is inflammatory, and it doesn't help with survival. On the bottom, you see the microfractured fat, which is much smaller. You can see about more than half of the adipocytes are gone. There's just a space where they were. And very, very good, healthy, intact stromal vascular fraction with pericytes. Now, don't ask me to identify a stem cell, because Dr. Rooney thinks he knows where they are, but I can't tell you, my little green arrow didn't come up today. Another view of the histology, and on the right, you can see the microfractured fat, and you can see it's very busy with cells. And on the left, you can see just a big clump of fat, which with not many pericytes or stem cells. So the surgical technique, we get the patients off of coffee, no blood thinners. We use a small cannula for liposuction, low suction pressure so we don't traumatize the fat, minimal exposure to air, and gentle manipulation with steel balls. We wash it extensively. And on the left, you can see the fresh lipoaspirate with some oil at the top. On the right, we're halfway through the process. The fat is now pure yellow, and eventually we wash it until that wash fluid comes clear. I guess I can show you this. And you can see there the fat rises to the top after microfracture, and the wash fluid is very clear. So this patient had 1,500 cc's pulled out, reduced to 850 cc. We did 450 cc into the defect and 20 cc's per side for additional augmentation. Small cannula for less tissue trauma, and a peristaltic pump which allows the fat to be put in very easily with minimum surgeon fatigue. Removed dressings after 3 days, and the patient went back to work at 2 weeks. And I think sometimes the best before and after is on the table when you've done one side and the other side is not yet done. I don't know if it's clear in the slide. Can people see a difference? At the top, the left is done, and I did it from the other angle. So now that cheek is on the right. And you can see where we broke up some of the different scar tissue and liposuctioned out some of the steatocnecrotic fat, replaced it with the liquidized fat for filling. At the bottom is the before and after. And the way we standardize this is to make sure that birthmark on the right cheek is exactly the same, so we can know we're comparing before and after. She wanted to show us how soft it was, so she gave it a poke. All right, so results. Patient had no excessive discomfort. Celebrex only for pain, and the fibrosis was resolving. Based on this outcome, we did 2 additional cases, 1,600 cc's and 1,870 cc's. And the last one was just purely cosmetic. 900 cc's of fat was obtained for injection. We split it 450 cc's aside. The modified quality of life questionnaire returned perceived scores of 19 for the very severe depression, and 11 and 10 was for the cosmetic case only. And the volume enhancement, skin change, and contour was evaluated by a patient satisfaction survey, which returned good scores as well. One last before and after. You can see on the right cheek was done and the left cheek wasn't. And so in conclusion, this is the first reported case of such mechanically microfractured fat being used for megavolume lipofilling. We did it successfully on a major and minor buttock deformity and a cosmetic case. And we feel like this technique is safe. The fluidized fat allows for injection to a peristaltic pump, which reduces surgeon fatigue. The smaller fragments conform to established criteria for good take of the fat. The regenerative properties of the injectate, such as decreased inflammation, angiogenesis, less swelling, less pain, might contribute to its reliability as a filler. And it avoids the need for a very risky technique of injecting fat into the muscle. Its use for purely cosmetic purposes is also justified, as all the patients showed improvement in their quality of life. There's some more studies we have on the horizon, but my time is up, so I just want to say thanks for your attention. And I guess sometimes the lesson is that you can get really close to the action, but if you put enough safety barriers in place, you can still be in a safe space. Thank you.
Hi, good afternoon. That was quite an interesting presentation, quite commendable. I just wanted to know, with your newfound success, if you'll be revisiting breast fat implantation and if it affects breastfeeding.
Thank you very much. The answer to both of those is I don't know if when you infiltrate the breast with fat, if it will affect breastfeeding. My inclination is that it would. For that reason, actually, all my implants are done in a submuscular plane so that I do not interfere with the breast in people who I'm doing breast augmentation on. I personally have not done fat injection in large volume for the breast. I've done it for lumpectomy defects, and it has worked well in my hands. But as far as large volume, I'm still kind of scared of that picture that I saw, so I'm backing off for now.
Speaking of large volume, but sample size, are you expecting a good series of these patients? Because I think keeping track of a good number of them and then looking for complications with a larger sample size would actually be a fairer thing before we claim a lot of what we have to claim.
I fully agree with you. We have, the last count is I have 7 people in the pipeline, but I couldn't present them because we didn't follow them up for 3 months. You know, 3 months is a cutoff where you decide, did the fat take or didn't it? So I couldn't present them, but yes, there's more in the pipeline. Thank you.
Okay.
Okay, I was hoping you wouldn't ask me that. I spent the last 20 years of my life setting myself up so I would never have to talk price with somebody. I feel like the total cost, including surgery center, it's an outpatient procedure, no overnight stay, might be somewhere in the region of $8,000 to $10,000. Thank you very much.
Thank you, Dr. Neal. He has a particular interest in cervical cancer and HPV-related diseases. Dr. Halliday has also exhibited an interest in virtual learning platforms, and he has been central to the introduction of the virtual learning platforms in our medical education program here. Today, Dr. Halliday is going to speak to us about the implementation and utilization of a live CME management system in the Bahamas. So let us welcome Dr. Halliday.
Good day. Thank you very much for that kind introduction. We sought to implement a live CME management system for a number of reasons. Some of the testers and managers are here today. Dr. Burrows, Dr. Dames could not be here. Dr. Roberts kept me in check because he kept telling me to watch the bottom line. And Dr. Butler was served as one of our testers together with the Department of Obstetrics and Gynecology. I have nothing to disclose, and the CME code has already been displayed. So continuing medical education is here to stay. It is part of the need to continue our medical care. It addresses the gaps in our local and professional practice. Dr. Neal illustrated this with his research and going to conferences that he had a particular problem where he thought the complications were too high, and he found a solution, and he was able to implement it safely for our Bahamian population. And of course, it reduces the need of medical errors. Now, the Bahamas has a long tradition of continued medical education. The MAB has had annual conferences for over 40 years, and each department have mandatory meetings on various days of the week. The hospital CME series has been in place for twice monthly meetings for several years, and the Doctors Hospital Health System has CMEs as well. In the early days, the community was very close-knit. all the physicians essentially knew each other, and if you go back far enough, I'm told they all went to the government high school. Approximately 5 to 6 Bahamian doctors were produced each year, but now each medical class has approximately 40 to 50 medical students, and there are many medical students who return after training offshore medical school. So there came a question: how do we keep the Bahamian population safe, and how do we ensure that our physicians are up to date? I remember Dr. Lund speaking several years ago when he said he remember when the first antihypertensive was induced. And of course, to us that seems like a long time, but he's very interesting to hear him catalog the history of medical innovations, and none of us would have known about these things without continuing medical education. So the Medical Council took the bold step, for which we are all grateful and applaud them, of mandatory CME attendance for licensure. And currently, this year was the first year where we had to report, and we require 10 general CME and 10 specialty specific CME. CMEs are to be free from commercial bias from medical products and devices, as well as drug company influence. We need to declare our financial interests, and by way of the application process, we need to apply 45 days ahead of the planned event. The number of points needs to be indicated on the certificate, as well as the name, the license number, the series name. Each certificate needs to have a unique serial number with the date of issue. And we had the challenge of the growing number of doctors. Our tradition was that we would hand generate each certificate after each CME meeting, and we wanted to implement a cost-effective automated system. And when we got together, we felt it should be online, so that it doesn't have to be done in-house. We don't have to buy any special software or any special devices, and that it could have wide dissemination. So we searched Medline for with the following search terms, as well as Google, and we searched for the terms CME tracking, online base, certificate generation, virtual classrooms, learning management system, and because we had a focus on cost containment, we explored all the open source options. The system must be able to provide feedbacks as well. So we came up with our wish list. This has to be cost effective, even though the income of the Bahamas is above many Caribbean countries. We felt this needed to be cost effective in order for it to be sustainable. It must be able to provide meaningful feedback, automatic analysis of the forms that we submit. It must meet all the certificate requirements for the Bahamas Medical Council. We wanted it to be a place for forums where we could discuss ideas, as well as provide automatic email alerts. And then we source this, and we also the tracking of CME points from other sites. We could do this, but we did not implement this because at the same time the Medical Council has launched its own CME tracking system. It must be scalable, upgradable, completely integratable with webinar platforms, and there must be local support and regional support, so we don't have to fly somebody from Japan if we have a problem. We excluded sites that offer CME courses but did not allow us to upload our own data, and the sites which cater to webinars only but not live events such as what we're having today. We emphasize it should be online, and systems that only cater to a single event as opposed to ongoing events were also excluded. So we found that the systems fell into commercial and open source categories. These ones were the leaders: eMed Manager, Okay, so they wanted to charge $7,500 for 15 courses, and every new feature you had to pay a modest fee. Then there was another one called CME Tracker, almost $9,000, and then we'll have to pay for further customization. Then we looked at Ethos CE, which is based on one of the open source platform. They just put their branding and customization on it. And they said it's available by request. Whenever you see this, you get suspicious. And I searched very long and hard, and I found out it's close to $10,000 to set up. But their site officially says by request, so that's what we have here. And Carl Versenal in 2004 published his review and found over 40 open source medical systems. So we were confused. Where do we start? Where do we begin? Which one should we choose? We decided to focus on what was hot and what was trending. And these 6 he identified in his paper as the hot and trending open source platforms. So which one should we choose? We said, well, remember our criteria is that somebody here has to be able to fix it, especially our local computer department at the University of the West Indies. How can we find the gem among all these other sources? So we asked ourselves, what does the University of the West Indies use? What does the BTVI use? That's our technical institute. And what does the University of Bahamas use? And when we looked, we were shocked. The platform Moodle emerged as the common platform for all these tertiary institutions in Bahamas. And when we checked with our computer department, they were very familiar with this platform as well. So even when we looked at other universities in the region, we saw a similar trend that this was the platform that we should go on. So we built our virtual server for testing to really see if it was implementable. And we tested this for 4 weeks. We digitized all the current paper forms. We tested it. I have to thank the Obstetrics and Gynecology Department for putting up with us as we sought to implement, and they went through all the teething pains until we got it right. And then once we were satisfied, it was deployed online until we came up with the site sunshinelearner.com. So the events that we managed during the first year was obstetrics and gynecology, pediatrics, accident emergency. We had a few conferences. We had the research day last year and the author and reviewer workshop, which was a combined workshop with the University of Bahamas and Ministry of Health and the University of Bahamas and other governmental agencies. And this is what we found. For single event, CME, meaning you come, you sat for an hour, we generated a certificate. For the general CME, we had 4 conferences, and we had an average of 58 automatic generated certificates. For obstetrics and gynecology, we had an average of 23 per meeting. Then for the lecture series, we could see that the number of participants and the number of certificate issued varied across the department. For research day last year, when we did the analysis, we found that 187 certificates were issued, although some people registered to claim their certificates, they did not. And bear this in mind that we had roughly 50 students registered, so this implies that almost every physician that registered claimed their CME points. And for our author and reviewer workshop, there were students and nurses and people who did not necessarily need CME points. So this would reflect why the number of CME certificates claimed is a little lower for that particular workshop. Now, with the prompt, this is our obstetrics annual drill, where we learn about obstetrics emergencies, and we had a total of 45 certificate issues with a number of CME points. So We tracked 2,529 CME points and issued 989 certificates. Now, who here would like to volunteer to do that manually? Now we have, well, I checked up to yesterday, we are now over 600 registered users on the site. So we felt that we were on autopilot, and the good thing is that the systems allows us to do analysis. And just for an example, this is the feedback generated from last year's research day, where over 80% gave us a rating of over 3 and 4. So that was very favorable, and we implemented the cake. Well, we implemented the cake, but we implemented the system because we felt that we met everything on our wish list, and the system performance during the first year was good. So CMEs are here to stay. We sought to comply with the medical council's requirement. We found a platform that met all the requirements, and we felt it's sustainable because it's open source. There is training that's complimentary by the company, and we did not have to pay additional for that. And we've used it successfully for a learning management system. There's some limitations. There's a bit of learning curve that's required, and not everyone claimed the certificates because of that. But so we've published a number of training videos on the website, and you can watch those at your leisure, and it would walk you through each step of registration, updating your account, putting in your BMC number. So for future directions, we hope to develop courses for particular medical issues. For example, the CME we had recently on antibiotic usage and abuses would be such ones. Dr. Dames and Dr. Hunt have developed started development of the interns portal. It's in its infancy, but this year it was used as part of the interns orientation, where they had to do mandatory courses on needle stick injuries and a few other topics to be approved before they could start their internship. Now, we also want to have regular live webinar CME events. We are actually streaming live right now. We stream to Freeport, and we are to other places in Nassau. And we did the same thing last year as a beta test, and we feel as if this is feasible. And we're hoping that we would have webinars all throughout the year. These are our references. So thank you. Any questions?
Okay, so we will continue to the next presentation. Our upcoming speaker is Dr. Robert Roker, a recent successful resident. So he has now graduated from the emergency medicine program. And Dr. Roper is going to present today on non-urgent patients' perception of the acuity of their presenting complaints in the accident and emergency department of the Princess Margaret Hospital. This is going to be very interesting. So thank you, Dr. Roper. Let us welcome him.
My name is Dr. Roper, presenting on non-urgent patients' perception of acuity of their presenting complaint at the emergency department of the Princess Margaret Hospital. This is a CME code. I have nothing to disclose. And so looking at the background information, approximately 65,000 patients present to the emergency department every year. Of these, 50% are non-urgent or ambulatory care patients. Now, overcrowding has been a significant concern in the emergency department, and these patients consume a significant amount of resources and compete with other patients of higher acuity. And so we wanted to understand what are their perceptions, the rationale, or why they choose the ED, and do we as the physicians who see them agree with them presenting to the department? And so this research was necessary. And so when we looked at the literature review, we found that USA, France, and Spain, 10 to 50% of non-urgent patients present there. And in Trinidad, approximately 70% of these patients are non-urgent. And so Berry et al. And Rokovich et al. Looked at the rationale as to why they presented, and they present for comprehensive evaluation because the resources are abundant in the emergency room, and because we're not going to turn them back. Moreover, the emergency department is open 24 hours a day. And so we hypothesized that patients perceive their complaint as having a high level of acuity, and their misuse of the ED was largely dependent upon diverse influencing factors. And we aimed to determine their perception of their acuity and the degree of concordance between the physician who saw them and their choice of the ED. And so our research question was to determine what is the relationship between these clients' perception of their presenting complaints versus those of the attending physicians who saw them. And our objectives included describing the socio-demographic profile of the participants to identify the perception of their perceptions of their presenting complaint, be it them or their guardians, the factors that influence their choices, and the correlations that may or may not have existed between the patients and the physicians with regards to the suitability of their care. This was a single-center prospective study with a cross-sectional design conducted over a 3-month period. We utilized the emergency severity index to determine the patient's category of severity. And so categories 4 and 5 patients were consented. 5 to 7 of these patients were interviewed on 2 randomly selected shifts. The questionnaire included their demographics, the perception of urgency of their presenting complaints, the rationale for choosing the ED, and the factors that influenced this choice. We also interviewed the physicians, consented them, captured their demographic information and experience that they had. They were masked to the patient's responses while asking them to determine whether or not the patient warranted ED intervention or could they have equivalently been managed at the community clinics. So our sample size was determined by the fact that 65,000 patients present and 50% of these were non-urgent. A piloting effort was conducted in 2014, and we also estimated that 3 to 4 patients would have deemed that their complaint was an emergency. So our minimal sample size was 302. We established anonymity of the patient and the physicians by assigning them numbers. Just to repeat that the physicians were actually blinded to the patient's responses. The information was downloaded into Microsoft Excel. Questionnaires were stored in a secure location at the university. And a qualified epidemiologist assisted with data evaluation to ensure accuracy of the statistical analysis. Dr. Frankson, of course. And ethics approval was obtained. So we included those who were triaged as category 4s and 5s and or their guardians if they were minors being represented by them. We excluded persons who were illiterate in English. We also excluded persons who didn't speak English and didn't have a translator with them. Persons who were triaged as categories 4 and 5s, but their acuity changed between the time that we interviewed them and the time that the physician saw them were also excluded. And persons who were previous participants or persons who qualified but refused consent were excluded as well. So what were the results? We canvassed 327 patients. Of these, 11 were excluded, 7 refused, and 4 were re-triaged to a high acuity. 316 of these patients were consented, and of the 316, 305 had corresponding physician questionnaire. So our sample size was met. We found that the predominant nationality was Bahamian, although Haitians and Jamaicans and other nationalities were other subgroups within that category. We found that there was equal distribution between both sexes, and that the modal age was 30 to 49 years of age. We also noted that the highest level of education for most of the participants was secondary, and to our surprise, approximately 67% of these patients were actually employed. These patients typically were uninsured 80% of the time, and if insurance were offered to them, 52% would still choose the emergency department for their care. Other patients would say that they would choose an alternative, or some were actually undecided. We found that 47 patients felt that the clinic could not have dealt with their complaint. However, to our surprise, 32.9% thought that the clinic could have dealt with their complaint, but still chose the emergency department for their care. Of the rationales given for choosing the department, patients stated that the clinic appointments were long, that they had a genuine emergency, that the ED was a one-stop shop, that they usually come here, but of all of these, they perceived that the clinic would have referred them to the ED, and that's why they chose us for their care. Now, most of these patients did not contact their healthcare provider, irrespective of the rationales given for choosing the department. And these patients were typically self-referred, and some of them did state that the appointments were long when they actually saw their healthcare provider, and others, when they saw their private doctor, would say that the clinic wouldn't see them at that point in time. Of the rationales given for choosing the department, musculoskeletal complaint represent the primary reason, and of the soft tissue injury was the highest. Now, the meat of the matter. Patients perceive their complaint as an emergency 80% of the time. And based on the box and whisker plot, you'll see that these patients were pretty sure, at least 80% sure, that their complaints were an emergency. Now, we asked these patients if they're willing to be redirected to the community clinics, if we could offer them alternative choice for care, and 67% of these patients refused. The rationales given predominantly was because they were already in the ED, because of the level of severity of their complaint, because of the resources that they had, and some of them even stated that they lost confidence in the community clinics. So what was the physician's perspective? We found that the physicians had at least 6 to 10 years of experience. And in terms of ED experience, 75% of these physicians actually had 3 or 4 years of ED experience. So they stated that 60% of these patients did not warrant ED intervention. And you could see in this chart that there's an inverse relationship between the perceptions of the physicians and that of the patients, irrespective if they thought their complaint was an emergency or not. Of the other rationales they gave, you find that an inverse relationship was established when the clinics, they thought the clinics would have sent them to the ED, when they thought the ED was a one-stop shop, when they gave other rationales for choosing the emergency department. And if you were a PMH employee, if you were referred by a friend, or if you were referred by the school, we didn't agree with you presenting to the department. And you'll find that 50% of the referrals from the community clinics were actually deemed inappropriate by the physicians who saw them. And so the discussion. We found that in our study, it was randomized between 2 shifts, and we did that to avoid patients saying that their complaint was that the clinics were closed, and this was only represented by 1% of the patients. And we based our decisions off the fact of the physician's knowledge and not based upon the nurses or appropriateness protocol that similar studies had done in the past. We found that in our study, similar to Durant et al., patients were typically males of a modal age of 30 to 49 arriving by private vehicle, typical demographic of the region, and they were uninsured, similar to Masso et al. However, contrasting another study, Rokovich et al. Noted that patients who were single, who viewed their complaint as non-emergent, but employed and widowed viewed their complaint as an emergency. In our study, neither marital status, nor job type, nor education level or employment influenced their choice of the department. We also know that these patients were self-referred, and the most common reason for presenting was for musculoskeletal complaints, similar to at least 2 other studies. We also noted that Gentile et al. Study that patients were willing to be redirected, but in our study, these patients did not want to be redirected to the community clinics. And Tsai et al. Said that 50% of these patients perceived their complaint as appropriate. In our study, 80% viewed their complaint as appropriate for the ED. And so, Sempre Selva dubbed these patients as inappropriate healthcare consumers. Durant et al. Dubbed them as rational consumers, and we think they were just misappropriators. And so the limitations of this study was that it was a single-center study, that the experience of the healthcare provider could have been come into question where we could have utilized consultants, and that might have kept the even par in terms of what the perception was amongst the physicians. The address of the patients were not captured, in that if a patient was from South Beach Clinic, for instance, and had issues, we wouldn't have known that. And the fact that randomization was only between 2 shifts. So what do we recommend? We recommend, first, by planting seeds. We have to educate the population, infomercials, handouts, day-to-day interactions. We have to add soil by establishing protocols, telling the clinics what is actually appropriate to refer to the ED, the school, and the police as well. We have to give them timely appointments, and this will increase their confidence within the community clinics. We have to establish resources and make them more available to the clinics in terms of radiography, laboratory testing. And the family medicine reticent actually helps them in terms of building confidence as to the appropriateness of presenting to the DD. And we want a tripartisan relationships between the clinic, the ED, and the Ministry of Health. These are my many references. I thank you.
Dr. Roper, thank you for such a lovely presentation. first time I've actually seen the presenter helping us out by boxing the international and the local findings and so on. Refreshing. My question to you and the accident emergency folks is, where do you take this now? Because the accident and emergency department of this institution that you did it at has an issue where that was the same place in general where the GPC was as well, next door to it, or upstairs. But the folks in this neighborhood have always seen over the years of Princess Margaret Hospital that this is their primary care center. How are you going to lift this now and help them to see in a more favorable light that they should desire to go to these other centers? Which agencies are you going to, from a policy standpoint as well as the health education, I know you do well, but from a policy standpoint, etc. When I say you, I mean you as a group of colleagues.
I think the decision has to be based upon a conjoint decision between both the clinic, our department, and the Ministry of Health. We have to give them something to turn to. I mean, their confidence level to the clinic to some extent is based upon previous experiences that they had in the past. And so changing the mindset of a patient is challenging, I would say. And it has to be a multidisciplinary approach. And so I think when we sit down between all the three groups, we should be able to come up with a plan in terms of educating, how to initially educate them, and then establishing how we could change their mindset. If that answers your question, Dr. Frankson.
Yes, Dr. Roper, very good presentation.
Thank you.
I would like to know, though, being friendly of the community clinics, how many of those cases
Yes, ma'am.
that you said did not have to present, how much cases, I want to know, that was sent in from the clinics was actually needed to come to the ER? Out of your whole grouping, how much of them was correctly referred to the ER?
Well, there were, in my recollection, because I don't have the figure in front of me, it was about maybe 60 patients who were referred into the clinics. Out of those, 316 patients. And out of those 60, 30 were inappropriately referred. Now, these patients sometimes don't have an actual referral with them in hand. And so most of the times when they come in, we hear, the nurse sent me here, the doctor sent me here, and so we can't really validate at some point in times if these are true, is it a true reflection of a referral or is it not? We just have to take them at face value in terms of the referral.
Okay, so out of that 50%, you're saying you can't ascertain whether they came on their own or they were genuinely referred?
They were referred. They said they were referred. Let me say it that way. But sometimes it's genuine because if you contact the community clinics, you'll get from the nurses that, yes, I did send the patient to the ED, even though they don't have a physical referral in hand. And so I can't say how many of those were, not true versus those who are true, but I could only base it upon what the patients had told us at the interview.
Maybe another study for us to look at, and maybe we need to do this at the community level to see how much cases we send into the ER were sent home that needed to be in the ER. That sparked my mind, so I'll be thinking about doing that.
Not a problem.
Thank you so much for a great presentation.
Not a problem.
I had a question in relation to the area that most of the complaints were musculoskeletal.
Correct.
Right now, I'm a physio and orthopedic clinic, so I would see a number of the patients that would come from A&E.
Okay.
So my question is along the lines of those patients, was there a differentiation between acute versus chronic? And then, depending on if it were chronic, was there any education of sort in relation to what we see now happening in pain science as it relates to catastrophizing and long-term adaptations for them in relation to their pain?
Well, we didn't actually capture whether or not the complaint was acute or chronic.
Okay.
That is a valid question, given that most of the patients who presented were for musculoskeletal complaint, and I guess in the future we could look into that.
Yes, and also an advocate for an emerging area of physio in the ER.
do our patients see the emergency room as a quick way of getting into the system? Suppose we had specialty clinics that will get into the next day or 2 days from being seen in the community clinic. Will it ease the burden of the emergency room?
I believe it would. Again, the thought process behind most of these patients is expedited care. I'm going to get my x-ray, I'm going to get my blood test, I'm going to get everything right in the emergency department. Why should I go to the clinic if they're going to turn me around, or I need a blood test, or it's going to take another day, come back another day? So even if you have specialty clinics in 2 days appointment, some of these patients will still, in my perception, believe that it's better to just come to the ED and I'll be expedited anyway. So in essence, if you make the resources available to the clinic where they can do the x-rays and do the blood tests, that would definitely alleviate the burden in terms of the ED.
I just want to add on to what Dr. Lochin just said, because I need to get this clear. I have referred patients to the specialty clinic.
Okay.
And the claim is that because you're coming from a private physician, you have to go to the clinic before you can go to the specialty clinic. Now, I've been in the system long enough, and when I send patients, I send them with a referral and all of the appropriate investigation. Instead, they're told that they have to go to one of the clinics, and then invariably when they go to the clinic, it's not that day for it's not a gynae day, yeah. So they're going to end up in the emergency room. So that needs to be fixed. I think we need to sort some of those issues out. Is this the current policy, or is this just that people have decided that this is the way it's supposed to go?
I can't speak to it at the level of the policy. I think that Dr. Wells or Dr. Burnett would be glad to answer you with reference to the policy. But I can't speak to the policy, sir. In reference to the community clinic, whether or not an outside referral is sufficient for them to get inside the ED, I can't speak to the policy in reference to that.
I stress this because it's even more important for the people coming from the family islands.
Agreed.
Okay? I spoke about this at the medical conference. It's even worse for them because they come to Nassau and they get, is the wrong clinic, is the wrong day, and of course they get turned around. So we need to fix that problem.
But for the most part, to stand in defense of the ED, when you come from the family island, we usually try to expedite most of these patients, whether it be investigation, admission, or seeing the specialty service on that day.
Yeah, but again.
But in terms of the policy, I understand your point,
I'm pushing this because your problem is overcrowding.
Agreed.
And so if you're going to be making everybody need to fix what's going on.
Agreed, sir. Thank you.
Thank you. So we've noticed some very brilliant public service announcements coming from the emergency department that have been educating the public about what constitutes an emergency, what things might be able to be addressed at the clinic as opposed to the emergency room. So do you think that possibly a review of your study after these public service announcements have been mainstream for a while might change your results?
Most certainly, most certainly. Thank you, everyone.
Thank you, Dr. Roper. Our next presenter will cause me to have to disclose moderator bias. So we have a presenter from the Department of Medicine. Dr. Dia Seville is in his final months of the internal medicine postgraduate program. Today he will be presenting H. pylori detection in non-varicose upper gastrointestinal bleeding in the Bahamas. Let us welcome Dr. Dia Seville.
Okay, good afternoon, everyone. So I know that the food has begun to settle and the eyes may be getting a little heavy, so I'll do my best to hold your attention, okay? So I want to discuss with you my research on Helicobacter pylori detection in non-varicose bleeding, upper gastrointestinal varicose bleeding in the Bahamas. So before I go on, I would just like to publicly acknowledge doctors that were with me throughout this entire process. I appreciate you and your dedication and hard work. I'm very grateful for. Okay, so I have nothing to disclose, and as we are very versed in, this is the CME code slide. So before I go in, what do we have here? So this is clean, white-based ulcer, actually in the area of the pre-pyloric region on an upper endoscopy. This here is a tumor arising from the mucosa in the stomach. This was biopsied and it came back as a malt lymphoma. This here is as we can see, exophytic mass. It's actually located at the incisura angularis on EGD, upper endoscopy. So you can see it's friable, necrotic. When this was biopsied, it was a gastric adenocarcinoma, okay? So what do these three diseases have in common? Helicobacter pylori. So Helicobacter pylori is also affectionately known as H. pylori. It's a gram-negative spiral-shaped bacterium. It is able to survive in the harsh acidic environment of the stomach, and this is attributed because of the enzyme urease, which actually cleaves urea to make it into ammonia, neutralizing the immediate pH of the stomach. And certain virulence factors can actually potentiate disease. 50% of the world's population is actually infected with H. pylori. Infection typically occurs during childhood, and the modes of transmission typically are either oral-oral or fecal-oral. And actually there have been studies where parents have actually transmitted H. pylori to their children. Also partners transmitting them between partners. Even something as simple as kissing. Patients have become positive when one spouse is positive and the other is not. Most people, however, despite the huge numbers, are asymptomatic. However, in some, chronic infection can actually lead to peptic ulcer disease, gastric adenocarcinoma, this is mainly the intestinal type, and also malt lymphoma. So these complications carry significant morbidity, mortality, as well as health costs. And with early detection and treatment, we hope that this can drastically reduce the impact of this disease. So this is just a list of the different diagnostic tests that we can use to diagnose H. pylori. You have invasive versus non-invasive. Invasive being through endoscopy, non-invasive being through blood sticks or the urea breath tests. So the rationale behind this research. So non-cardiac gastric cancer is thought to be almost exclusively related to H. pylori. In the Bahamas between the years of 2006 to 2016, there were 221 cases of gastric cancer diagnosed. 72% of these cases were actually located in the non-cardiac region. H. pylori-related peptic ulcer disease can lead to upper gastrointestinal bleeding. And actually here at Princess Margaret Hospital, the #1 reason to get an EGD is upper gastrointestinal bleeding. There is a paucity of research in the Caribbean pertaining to H. pylori prevalence. Actually, only 2 studies have been published, these being in 2010, 2012. So in 2010, Dr. Whittle, Dr. Ewing, Dr. Lee, he actually did some work in Turks and Caicos, where they looked at about 56 patients over the period of about 2 years, and they had a prevalence of 52.6%. of H. pylori. The average age of those patients were actually 43 years. This was through histology, and this was quite interesting in terms of their findings. Our very own Dr. Carter actually looked at elementary school age children, the average age being 9 years old. He looked at asymptomatic children using the urea breath test. 96 children, 52.6 actually were positive for H. pylori as early as 9 years old. In the Caribbean, there's no research on H. pylori prevalence in patients that particularly present with an upper GI bleed. So the aim of this study was to detect H. pylori in patients that are admitted to PMH with a non-varicose upper GI bleed. We wanted to describe the prevalence in patients that presented with a non-varicose upper GI bleed with a rapid urease test or using histology. And we wanted to also compare the rapid urease test versus histology in terms of detection. We also wanted to identify if there were non-modifiable risk factors associated with H. pylori infection, such as certain demographics listed below. And also we wanted to determine whether or not there were risk factors related to peptic ulcer disease that seem to potentiate H. pylori infection. So how did we define histological detection of H. pylori? So patients could have any of the following: chronic active gastritis, atrophic gastritis or intestinal metaplasia, or you were able to actually see the bacteria on the slide on H&E stain. So the rapid urease test that we used was actually a rapid, ultra-rapid urease test. These tests can actually be positive within a minute. However, after 1 hour, it can be considered negative. The normal conventional rapid urease test, it takes about 24 hours to say this is truly negative, okay? So what we hypothesized was that 65% of these participants will actually be infected with H. pylori. We thought that histology would yield a greater prevalence than the rapid urease test. We thought that non-modifiable factors really didn't play a role, and also NSAID use or aspirin use would actually cause an increase in upper GI bleeds in patients infected with H. pylori. So the study design was a single center, observational cross-sectional study, and the duration spanned a period of about 8 months between September 2016 to May 2017. All patients that presented to PMH with a non-varicose upper GI bleed were the target population, and the available population was anybody who presented within that time frame that the study was started, who had an EGD. The inclusion criteria were anybody between the ages of 18 to 80 years old, and they had to have a documented evidence of upper GI bleed, and this was through either coffee ground hematemesis or frank hematemesis with melena prior to presentation, evidence of an upper GI bleed through NG tube drainage or nasogastric lavage, or there was evidence of a drop in hemoglobin on presentation. Exclusion criteria were proton pump use within the last 2 weeks, H. pylori treatment within the last 4 weeks, if they were given an antibiotic that was known to be effective against H. pylori within the last 4 weeks, or when they had an EGD done, they had viruses on their upper endoscopy. So the projected sample size was 81 patients. However, our actual sample size was 13 patients. So what happened? 25 patients were actually enrolled. However, 12 had to be excluded. 7 had their upper endoscopies canceled on the day of the procedure, and the reason for this was actually due to time constraints or ancillary staffing issues. 5 had an EGD, however, no rapid urease test was done. So these patients subsequently had to be excluded. And the reason for the lack of testing at the time of the procedure was due to human error. So all ethical requirements were forced and fulfilled, and after each patient was consented, each participant had to fill out a study questionnaire. And this is the study questionnaire looking at age, the different demographics of level of education, socioeconomic status through household income, comorbidities, risk factors for peptic ulcer disease, or whether or not they had risk factors for bleeding. So during the upper endoscopy, gastric biopsies were performed. The first sample was used for a rapid urease test, and this sample site was actually taken from the greater curvature of the body. Other biopsies were performed in accordance with the updated Sydney system, and if patients actually had observed bleeding at the time of upper endoscopy, one biopsy site sufficed, and this was the greater curvature of the body. Samples were sent to the lab and were read by a histopathologist, and the staining method that was used was H&E. So the results. So of the 13 patients, 9 were actually males. The mean age for males was 58.7 years. The mean age for females was 66.3 years. The average age of each participant was 61 years, the youngest being 38 years old, whereas the oldest was 77 years old. In terms of the highest level of education achieved, 70% had actually achieved up to a secondary level of education. 15% actually had achieved either a primary school education or a bachelor's degree. In terms of household income, 46% of patients actually fell within both either the range between less than 16,000 or between the range of 16,000 to 29,999. 8% actually fell into the bracket of 30,000 to 74,999. And this was a distribution of the comorbidities for the patients in the study. And as we can see, diabetes and hypertension were most represented in the study population, which was reflective of what our society is. 4 patients reported daily use, 5 frequent NSAID use, and 4 reported no aspirin or NSAID use. 1 patient was taking clopidogrel. The reason for was a TIA, and the other was taking dabigatran for atrial fibrillation. So the results actually showed that 69.2% of patients were actually had a positive rapid urease test. And on histology, 76.9% actually had a positive histology for H. pylori. Also, what we noticed was there's a strong positive association existed between household income and a positive rapid urease test, but this seemed to lack statistical significance. And also we saw that there was no relationship observed between H. pylori infection and specific comorbidities. In terms of looking at whether or not NSAID use or aspirin use was related to the positivity of a rapid urease test, we looked at the 4 patients who had a negative rapid urease test. 75% actually had frequent NSAID use. But looking at the 9 that were positive, just 22.2% actually reported frequent NSAID use. So this implies that most of the patients that were positive were really not taking NSAIDs. However, this was clinically significant. No statistical significance was actually seen. So when we looked at the histology, once patients were confirmed to have H. pylori positivity, the #1 histology pattern seen was chronic active gastritis. This actually just came in at just below 77%. Second was intestinal metaplasia. And third was atrophic gastritis at 7.7%. So how did NSAIDs and aspirin use measure to histology? So this was a very interesting concept that we observed. In terms of looking at aspirin and NSAIDs with chronic active gastritis, only 20% of participants who had chronic active gastritis actually reported frequent NSAID use. This actually was different than a study done out of Italy. It was by Mangoso and also Riccio. They looked at patients who had H. pylori infection with a bleeding peptic ulcer, and all of the patients, they looked at 80 patients, actually had NSAID use. And they found that 42% of patients actually had H. pylori infection. So there seemed to have been some overlap based on their study. However, this was actually seen to be an inverse relationship in my study. And in terms of atrophic gastritis, there was very little to no correlation. And when then looking at intestinal metaplasia, only 2 out of 4 patients reported NSAID use. However, in the 9 without, 3 reported frequent NSAID use. So using rapid urease tests and histology, H. pylori prevalence was 69.2% and 77% respectively in the patients that presented with a non-varicose upper GI bleed at Princess Margaret Hospital. There was no correlation between the modifiable factors. There was little to no correlation between H. pylori and frequent aspirin or NSAID use, and an inverse relationship was existed between chronic active gastritis and frequent NSAID use. So this is a pilot study. More patients are needed. In the Bahamas, the true prevalence of H. pylori in patients that present with a non-varicose upper GI bleed must be determined. Ongoing research may potentially impact the management of such patients, especially in a resource-limited setting. Here in the Bahamas, H. pylori is a problem, and we must be aware of it. Through awareness and prompt treatment, we can decrease H. pylori-related diseases, and with more research, we will see what the future holds. Any questions?
So in the interest of time, we are actually going to go on to our next presentation.
Okay.
So thank you, Dr. Seville.
Thank you.
Our next presenter is also a resident in the Department of Internal Medicine, Dr. Gerardo McIntosh, who will be presenting the epidemiologic profile of cases of tuberculosis from 2014 to 2016 at the Princess Margaret Hospital.
Good afternoon, everyone. I will be presenting on the epidemiological profile of cases of tuberculosis from 2014 to 2016 at Princess Margaret Hospital. I have nothing to disclose, and this is the CME code, and this is an overview of my presentation. Tuberculosis is considered to be one of the oldest diseases known to man, yet it is still considered one of the top causes of death worldwide. In 2015, the World Health Organization reported 1.8 million deaths and 10.4 million new cases worldwide. The Bahamas is considered to be a country of intermediate burden of tuberculosis, at 18 per 100,000 persons being estimated to be infected in 2015. And there are various risk factors which I will discuss later in the presentation. The aim of our study was to describe the clinical epidemiologic profile and risk factors of patients with cases of active tuberculosis diagnosed between January 1st, 2014 and December 31st, 2016 at Princess Margaret Hospital. Our objectives were to determine the associated risk factors with reported cases of TB per 100,000 between the years, and the percentage of TB HIV co-infection. We also determined if diabetes mellitus was prevalent in patients with TB, as well as a number of culture-confirmed cases. This was a retrospective study chart review of the patient's medical records, and we examined cases of active TB between the study period. Our inclusion criteria included all cases of clinical and culture-proven TB within our study period. Exclusion criteria included cases of active TB diagnosed outside of the time frame, patients diagnosed with latent TB infection, and cases diagnosed in other institutions other than Princess Margaret Hospital. 201 cases were reported within the Bahamas between 2014 and 2016, and 189 of these cases were reported at Princess Margaret Hospital Chest Clinic. This gives a breakdown of the data that was collected for our study, and I would go through each one in the results section. The data collected was imported and analyzed using IBM SPSS software. As we can see, 46 cases were diagnosed in 2014, 60 cases in 2015, and 83 cases in 2016. And this accounted for 12.5 per 100,000 in 2014, 16.1 per 100,000 in 2015, and 22 per 100,000 in 2016. 56.1% of our cases were males. The mean age was 37.96, with the age ranges from 3 months to 77 years old, and most of the cases were between the 20 to 39 and 40 to 59 age groups. In terms of nationality, Bahamians, it was 60.8% Bahamians, 35.4% Haitian, 2.6% Jamaican, and other included 1.1%. HIV status was known for 9.6% of cases, and of that, 40.1% of patients were HIV positive. And this gives a breakdown of various other risk factors that we investigated, ranging from cigarette smoking, alcohol use, whether the patient had an ill contact, whether or not they have diabetes mellitus, or whether a history of recent travel was elicited. There were 96.3 cases of pulmonary tuberculosis and 3.7 cases of extrapulmonary tuberculosis, accounting for TB, lymphadenitis, meningitis, and disseminated tuberculosis. This gives a breakdown of frequency of symptoms that are reported by patients, and as we can see, cough, weight loss, and fever were the top 3 reported symptoms. In terms of the tuberculous skin test or MANTU results, we analyze it based on HIV status, because we do know that HIV would be a confounder. And we found that of those patients who were HIV negative, 64.7% of those patients had a MANTU that was greater than 15, which in the absence of other risk factors is considered significant positive. And we see, however, that 35% of these patients presented with a tuberculous skin test that was less than 15 millimeters. Of our HIV positive population, they are immunocompromised. Normally the cutoff would be anything greater than 5 millimeters would be considered positive. We see that 68.2% of patients had a MANTU between 0 to 44, which sometimes can be expected depending on the CD4 count. There were 157 cases which a positive radiological finding was found, and in 9.2% of cases the patient had a normal chest x-ray. We investigated the various radiological findings that were found, and we see that the majority of patients either had an upper lobe consolidation or middle to lower lobe consolidation. We further compared the radiological findings based on HIV status. And what we see is that the 2 statistically significant findings were cavitation and atypical findings, being HIV negative patients were more likely to have cavitary lesions, and HIV positive patients were more likely to have atypical findings. Acid-fast bacillus smear was positive for 21.8% of the patients, and AFB cultures were positive for 52.5% of cases. So the positive cases were account for the culture confirmed cases, and the remainder would account for cases that were thought to be clinical cases. Based on the patient's addresses that were given, the GPS coordinate was found, and it was plotted on the GPS software. And this gives a breakdown of where the cases of TB were being reported. And as we can see, a lot of cases were being found within the East Street, Wolf Road, Blue Hill Road area. So in terms of my discussion, within our study, we see that we've had 39.2% of the patients in our study were non-Bahamian, so they were foreign-born. And when we compared it to other studies, such as the United States, Switzerland, and European Union, we can see that foreign-born, whether or not the patients with TB were foreign-born or nationals, varied based on the location. In terms of HIV testing rate, 96.3% of our patients were tested for HIV, and our testing rate was basically the highest I found in any other literature that I've seen. The other highest being in Sydney, Australia at 87.1%. We see Montreal, Canada had a testing rate of 58.8%, and Southern California 30.1%. And in terms of TB HIV co-infection rate, we had a co-infection rate of 40.1%. And in general, studies have shown that places where you have a high prevalence of HIV, you would expect there to be a higher prevalence of HIV-TB co-infection. So in a country such as the Bahamas, where the HIV prevalence tends to be one of the highest in the region, we can see why we have such a high co-infection rate. In terms of tuberculous skin testing, more specifically focusing on HIV-negative patients, we see that 35.3% of these patients would have had MANTU that, in absence of other risk factors, would consider to be negative. And in a way, this could be alarming, because if most times the MANTU would be the only means at which, one of the means at which we use to screen persons, so these could be possibly 1/3 of our patients who would have been falling through the cracks if they had been tested previously with the MANTU. terms of radiological findings, we know that in tuberculosis in immunocompetent patients, reactivation of tuberculosis would present as an upper lobe disease, whereas primary TB would present as lower lobe disease in patients who are HIV infected. But in our study, there was basically no difference between HIV positive, HIV negative in terms of the presentation of upper versus middle to lower lobe consolidation. 21.8% of our patients were smear positive, and 52.5% of our cases actually had a positive culture, and the culture is really the gold standard for diagnosing tuberculosis, with patients being HIV negative being more likely to have a positive culture than HIV positive patients in our study. And so in conclusion, what did we learn from this study? Well, we've always known that HIV would have been a major risk factor, but we also have seen that 1/3 of our HIV negative cases had a TST result of less than 15 millimeters. And we see that half of our cases are actually have been negative for tuberculosis. And as clinicians, it leads us to further want to explore, well, why are these cases coming back negative? Does it have to do with the way that samples are collected and handled, or could be simply that sometimes we tend to overdiagnose tuberculosis? What could we do? Well, prevention is always better than cure. So for example, for HIV positive patients, we see that yes, once patients are coming in with tuberculosis, they are being tested for TB. But of our HIV positive patients, we need to further evaluate how much of these patients are actually being screened for tuberculosis prior to presenting with the disease. And based on the map that I have shown, we see that communities where you can see that there are a higher number of cases, whether or not we should consider implementing something at the healthcare community level where we can go into these communities and screen persons, not necessarily going door to door placing mantus, but for example asking, does anyone have a chronic cough, fever, chills, or basically asking if there are any symptoms. So these are my references. Any questions? Thank you.
At this time, we'll open the floor if there are any questions.
Thank you very much, Dr. McIntosh. And it reminds me going to the lab just this past week and alerting them that I had a sample that I went for TB culture, and I was giving them, this is your sample and I have the other one. Well, the technician told me, no, all the samples come to me first, because they have a special processing for any suspicious cases of TB. So even though I didn't really think this was a TB case, it was one that was a diagnostic dilemma, and I just threw that in. I didn't think that I had to do much more, but just a reminder about sample handling is important, not only with regards to trying to get the diagnosis established, but the protection of staff.
Just a quick word. Do you have a quick testing for TB, like the NAAT, nucleic acid amplification test? They give you the answer within 100 minutes rather than 3 weeks or whatever. Do you have that kind of test yet?
Pardon?
The nucleic acid
do we offer the nucleic acid amplification testing at PMH, you're asking? I'm not sure. So I don't know if anyone do we offer? Okay, so I'm being told do we offer the nucleic acid amplification testing at the Princess Margaret Hospital for samples of tuberculosis for TB? Okay,
that will give you also
consensus would be no, it would be done at doctor's hospital.
That will give you a rapid answer to whether you got multiple drug resistant as well, you see. That gives you a rapid answer to multiple drug resistance. And number two, how long are you treating your TB cases now?
So for general in persons who are HIV negative, the treatment protocol, sorry, you're asking for the treatment duration?
Yeah.
So for HIV negative persons, it would be 6 months. For persons who are HIV positive, we generally use 9 months, with the first 2 months being treatment with RIPE-B6.
Yeah, same as what I heard a couple of years ago. Yeah, because at first, when I first arrived here, it was 1.5 years, which then Brompton Hospital said, you're overkilling. You only needed 6 months, and 9 months perhaps if you're HIV positive.
Yes,
yeah.
Okay.
Thank you, Dr. McIntosh.